Today, we'll do an overview of the diagnosis of lymphoma with an introduction to this new WHO classification that just came out actually almost only a month ago. So it's brand new. So obviously this is a vast topic and we can only touch on general principles without going into specific entities. We will discuss the general principles of how a diagnosis is made, what are important components of that, and also we'll touch on some new entities that have been introduced by the WHO. So like any diagnosis in healthcare, this is an integrated approach. It requires input from obviously the clinical information. Radiologic findings are frequently very important. And then for reaching a tissue diagnosis, there can be different ways of doing it. You can do a fine needle aspiration, which may be the initial screening way of doing it, less invasive, and it gives you an idea of what entity you're dealing with. Then histopathologic evaluation, which will go into further detail of different types of specimens that can be submitted. Flow cytometry is an invaluable technique, especially for those lymphomas that are circulating in the blood or present in the bone marrow. In fact, flow cytometry is one of the most sensitive techniques we have for diagnosing them. But that's actually more of a hematology topic, so I won't get into that in too much detail. And then molecular testing is obviously, it's here right now and it's going to be increasing. And I think that is the future. But it's important to realize, especially in a setting like Pakistan, where even access to some of these basic things is limited, that molecular testing needs to be done in a very judicious way. We cannot, like some other countries, just do molecular testing on each and every case without, like this shotgun approach is not. So we have to do it in context, where it's necessary, where it will guide our diagnosis, where it will guide the therapy. So I think definitely that is part of the algorithm here, and we'll touch on that as well. So the clinical information naturally is invaluable, but it comes with the fact that lymphadenopathy is a very, very common symptom. We're all aware of that. Causes are multiple causes. And one of those favorite questions in examinations, causes of lymphadenopathy, and it's pages and pages of causes. And that's why an FNA or a biopsy or something is done. In a country like Pakistan, where tuberculosis is endemic, a lot of patients do get empirical TB therapy, and then a lot of the biopsies we get actually 3 or 4 months of therapy, and then they do the biopsy, and sometimes there's lymphoma, sometimes there's something else. Other things like hepatosplenomegaly, cytopenias. Naturally, the age is very important. Not so much gender, but age, because the spectrum of the kind of lymphomas you expect to see are different in pediatric population, different in young adults, and somewhat different in older adults as well. Additional constitutional symptoms, fever, weight loss, malaise, etc., they can be helpful. And very, very important is when there is a previous diagnosis. The reference to that, what type of lymphoma is it? Sometimes we get biopsies saying previous lymphoma. It's obviously helpful, but it's not that helpful. So a lot of times we try and get a reference or a report for the previous diagnosis. And that really, instead of going blindly into it, you know then. And then therapy. Therapy now more and more, especially with these monoclonal antibody therapies that will result in certain antigens being blocked. And that will also actually affect our interpretation. I think the most prominent example is anti-CD20 or rituximab therapy, whereby something that we normally diagnose B-cell lymphomas on doing a CD20. In those cases, if they've recently had therapy, then CD20 stain comes out negative. It changes our thinking completely. But if we know that the patient has been on therapy, and especially if we know they've received rituximab, then we can do alternate B-cell markers and still reach a correct conclusion. So all of this is information that should be provided so that the pathologist can reach a good diagnosis. And in cases in which these are not available and we are suspecting something that requires clinical correlation, Our practice is to call the patient, sometimes to request the number for the doctor, and sometimes having a conversation with the submitting clinician or the oncologist solves a lot of the problems and makes things clear on both sides. So the pathological diagnosis, it's a combination of this cytomorphology of individual cells, the overall architecture of the lymph node or whatever tissue is, and the immunophenotype. What antigens are they expressing? Are they B cell markers, T cell markers, some other antigens as well? And very important thing for this is proper fixation of whatever specimen is being submitted, processing in the lab, how well the sections are cut on the microtome, and then the quality of the staining. Because lymphoid tissue, all tissues are sensitive, but lymphoid tissue is really very, very sensitive to crushing and pore processing. And the difference between a thick pore quality section and a thin section is day and night. So sometimes with suboptimal sections, it can really make making a diagnosis much more challenging. And that is the backbone for pathological diagnosis, are good quality slides. So the hematoxylin and eosin or H&E is basically the bread and butter of pathological diagnosis. So everything else is secondary to that. Immunohistochemical stains, which ones are required, how many are required, and if you think further molecular testing is going to make the diagnosis, all of that is guided by a good quality sample and then optimal processing of that. So a little bit about the immunophenotype. So as we'll get on into the WHO classification, so some things they say are essential and some things are, I suppose, they're on the wish list, but they're not available everywhere. In this day and age, it's thought that having an immunophenotype is, for the diagnosis of lymphoma at least, is considered now an essential. So the immunohistochemical stains can be done on histopathology samples, such as cores and excisions. They can be done on cytopathology cell blocks, where a lymphoma is being suspected, and you can sort of centrifuge and make a block of the cells. Again, you lose architecture, but you can do stains. And sometimes, rarely, they can even be done on FNA smears, although that the sort of the technical issues there are quite a lot. Then flow cytometry is an alternate way of doing immunophenotype as well. That is basically various antibodies to different antigens that are fluorescently tagged, and you evaluate in that way. So in a lot of places where they have unlimited or almost unlimited resources, routinely on cases where lymphoma is suspected, they will do hematoxylin, eosin staining, and immunos, and they will also submit a part of that tissue for processing for flow cytometry as well. So since that can only be done on fresh tissue, that something has to be thought of upfront. You have to send the tissue in either saline or RPMI or this fresh, and then a small portion of that will be taken for flow cytometry. But in our setting, at least, this is not something we're doing routinely, and the cost of flow cytometry actually makes it quite prohibitive to do in all cases, or even in a few cases as well. So the important thing is you cannot diagnose, or you should not diagnose lymphoma without an immunophenotype, even in cases that you are 80 or 90% sure on morphology. The recommendation is to do immunophenotype to confirm that. The thing is that there are morphologic mimics. Sometimes you think it's something, it ends up being something else. Even having been doing this now for going on 20 years, there are many cases in which I tell my trainee that this is what it's going to be. And the next day I'm proven wrong when the immunomarkers come along that it's one of those mimics. So it's not infrequent for that to happen. But there are obviously in Pakistan now more and more labs are doing immunos, and I think it's quite widely available now. But there still are laboratories that do not do it, and I think the better places are giving a morphologic impression, and they are recommending stains. And I see that more and more in cases for consultation, is that they're giving a diagnosis, or this is what is favored, and then they're recommending immunomarkers for further confirmation. This is obviously not only in lymphoma, in other things as well, but certain other non-lymphoma diagnoses can be made with confidence. If it's adenocarcinoma or squamous cell, you can diagnose that with a great degree of confidence in well-differentiated tumors. But in lymphoma, I suppose the standard of care right now is to do an immunoprofile to confirm whatever your diagnosis is. So this just, I don't have a lot of images here since I think the audience is probably less pathologists. So this is just a section from a lymph node showing that the normal architecture is completely effaced. You have a proliferation of sort of all these cells, and a higher power reveals that some of these cells have nucleoli, they have a moderate amount of cytoplasm. So these would be classed as large size cells. And with this type of morphology, the list of things, the likely diagnosis would be a lymphoma, but what type of lymphoma? The most common is the B-cell lymphoma, but sometimes T-cell lymphomas and even non-lymphoma things can look like this as well. So that's where immunostains come in really handy. So if this is a CD20, which is a B-cell marker, and you see good expression in the majority of the cells, then you're confident that these cells are of B-cell lineage. Again, if you do a 30 as well, many of these B-cell lymphomas are 30 positive as well. So if you look at 30 alone, you would come to a different conclusion. If you look at 20 in conjunction with it, your diagnosis would change. So again, emphasizing that immunophenotype normally does not mean just doing one antigen. It's multiple antigens that are evaluated, and that the number is obviously, some places may have ready set panels for certain diagnoses, but a lot of times it's at the judgment of the pathologist who's evaluating the case. And sometimes we do get requests for certain immunomarkers later on, which have either for both diagnostic as well as prognostic implications as well. And the other important thing is that the markers that we do in lymphoma, they're expressed on both normal as well as tumor cells. So a B-cell marker like CD20 is expressed on normal B cells and on B-cell lymphoma cells, and sometimes aberrantly expressed on even non-B cells. So the interpretation is not black and white. It's always, you have to interpret it in context. The other important thing that I always emphasize is that no single antigen or marker is specific for a particular diagnostic entity. So CD30, for instance, is seen in Hodgkins, is seen in anaplastic large cell lymphoma, is seen in some other T-cell lymphomas, definitely can be present in reactive immunoblasts, can be expressed in non-hematopoietic tumors, certain germ cell tumors and other things. So it's what diagnosis you make from a positive CD30 will depend on that context. And the context is evaluation in the context of morphology, which cells are staining, how intensely are they staining, what other markers are expressed. The other thing that obviously goes without saying is that all of these immunomarkers are very sensitive, and they should be, the lab that is doing them should have a robust quality control. They should be running controls at the same time. And the best control is obviously an internal control. If there's normal cells in your sample that are staining, then you're confident that this stain has worked. If there are normal cells there that don't stain, then probably the stain has not worked. So this is an ongoing thing whereby immunomarkers run in any lab on a daily basis, or even more than one batch in a day. They do run controls in parallel. And if those controls are not proper, then that run would be invalid. Things have to be repeated. So a word about molecular testing. So molecular testing is a very useful adjunct, both for the diagnosis, definitely for identifying therapeutic targets, and also for prognostic evaluation. A good example for prognostic is actually P53 testing in cases of CLL, SLL. Right now, I think as soon as that diagnosis is made, the first thing that's requested is FISH for P53. That basically stratifies this CLL into those cases that generally you can take a more cautious or wait and watch approach to, whereas those that will require immediate treatment and are likely to behave in a more aggressive fashion. So that's where this single test is giving you a lot of information beyond what just the immunophenotype or the morphology is giving. So in Pakistan, with obviously increasing costs, and especially since the rupee has rapidly devalued, almost all of these probes unfortunately, are import items, and their cost has increased a lot. So we do have resource constraints. So it makes sense to do things in a sequential or manner rather than wasting resources. So, and this targeting is guided by the clinical context, what therapeutic options are available to the oncologist, and obviously based on histopathology as well, what entities you're considering and what are likely to be present. The other important thing is that results of these tests, like everything, should be evaluated in context. Most of these markers are not specific for a particular entity. In fact, the same things can be present sometimes even in non-lymphoma entities as well. So it's very important to evaluate in that context. So when we require, when we do molecular testing in our lab, we either require that the sample have been reviewed or diagnosed at our lab, or we require that a pathological diagnosis should be available from an outside lab that should be there at the same time.
यहाँ लाइन नहीं आ रही लाइन अब कौन सी
रेड लाइन आ रही थी अब गायब हो गई
कौन सी
I think we were here.
Okay, molecular testing.
Okay. So,
yes, sir, it's fine now.
Okay. So going on now to the role.
Dr. Asad, please kindly if you unmute your mic.
Okay, sorry. So coming to the role of cytopathology or fine needle aspiration in the diagnosis of lymphoma, it has an important role for two reasons. One, it's certainly much less invasive than an excision biopsy and may be done as an initial screening to evaluate the cause of lymphadenopathy. The other thing is in cases of already diagnosed lymphomas where therapeutic response is being evaluated. Many a time on imaging, the lymph node that is suspicious, or if a PET scan is being done, is avid on PET, is at such a site that it's not possible to do an excision biopsy. That is where either by EUS or EBUS or some other radiologic guided, you can get an aspirate of that. And naturally, there are two settings. There's the initial diagnosis where generally, I think cytopathology is a little difficult to get an initial diagnosis. I suppose the exceptions there are Hodgkins and diffuse large B-cell lymphoma. Because in Hodgkins, if you have a good background and you have large cells, and if you have material for a cell block, and you can do the immunoprofile there, you can make a diagnosis of Hodgkins on FNA. And the other thing is diffuse large B-cell lymphoma, because there are sheets of large cells. And again, if you have a cell block or you can do immunophenotype, that can reach a diagnosis. It also depends, I suppose, on how accessible the site is, since the treatment of all of these lymphomas is long and expensive and carries a lot of side effects. So generally, I think the practice, at least here at Shaukat Khanum, is to request a tissue diagnosis for further confirmation, even when you're quite reasonably sure of the diagnosis. So for accessible sites, we do like to have a tissue diagnosis to make the initial. For relapse settings, sometimes it's not possible to do that. The other thing is that since when you put a needle in any lymph node, there are a lot of lymphocytes, small ones. And on looking at them, you cannot readily distinguish if these are normal lymphocytes or if this is a low-grade lymphoma. So then the diagnosis of a low-grade lymphoma is very challenging on cytopathology. That's where flow cytometry actually is a very useful way of evaluating. And in cases where lymphoma is suspected either on clinical grounds or on the smear, sometimes we ask for 2 or 3 passes to be done, and we submit that sample for flow cytometry. And that can give us a diagnosis as well. The downside, obviously, of cytopathology is that we lose the architecture of the lymph node that we can see on tissue. And those lymphomas where architecture is an essential part of the diagnosis, that's where cytopathology is sort of lacking. So it comes with pros and cons, like everything. So TRUCUT or core biopsies, these are very commonly received specimens. And naturally, the amount of tissue sampled is of paramount importance. I would say the diagnosis of almost all types of lymphomas is possible with an adequate size and number of cores. If you have 3 to 4 cores of like 8 to 10 millimeters, not crushed, I think there are very few lymphomas that you would say you cannot diagnose on a core biopsy. So core biopsies are good samples, but obviously not all cores are equal. And the other setting where you already have a diagnosis, and like FNA as well, where you have a strong clinical and radiologic suspicion of relapse, and you just need a tissue diagnosis to confirm that before going to a second-line therapy or something, then that's where a core biopsy is much less invasive, and sometimes it's quite good to reach that. The other, obviously, the point with FNA and cores is that if the process involving the lymph node is very focal, that can be missed, but that's obviously a pitfall. Sometimes even in a lymph node biopsy, you may get the non-involved lymph node and the involved lymph node may be left behind. So, but I think I have no problems with core biopsies, and you can do immunostains, you can evaluate most of the architecture on good quality cores. Excision biopsy is naturally the gold standard for histopathologic diagnosis. And I want to emphasize that fixation is really very, very important. So good quality 10% buffered formalin is essential. And our problems with excision biopsies are usually where either the fixative is added with a delay or the fixative is of poor quality. And that's where, especially if these are being transported from a somewhat distant location, by the time they reach the lab, we have a lot of autolytic changes which limit both morphologic evaluation and sometimes even make evaluation of immunohistochemical stains very challenging. The other point I have is that sometimes pores or small biopsies actually have a superior morphology to very large nodal masses. So I think masses of 4 or 5 centimeters, because formalin is very slow. You normally say that the rate of formalin fixation is 1 to 2 millimeters per hour. So if you have something that big, only a small part of it will be properly fixed, and the center of the lymph node will have poor morphologic details. So that's where I think if there's a large mass being incised or cut by the surgeon, can actually help in fixation a lot. There'll be direct surface for fixation. And if you're suspecting a lymphoma, and if margins generally are not really that relevant in cases even of non-lymphoma things in lymph nodes. So if margins are not relevant, a large nodal mass, if incised or sliced a couple of times, I think that improves the quality of fixation and makes diagnosis better. The other thing is that normally the amount of tissue we need is not much more than a couple of representative lymph nodes if they are definitely enlarged. Usually 1 to maximum 3 lymph nodes is more than sufficient for diagnosis. So infrequently what we're getting here is we're getting whole lymph node dissections, neck dissections, axillary dissections. So many nodes that I mean, we can't even sample them all. So that I think is definitely overkill. If you don't know what the diagnosis is, then even then I think it makes sense not to take everything out. Obviously, if you know a diagnosis, you're going in for staging, that's different. But if you're going in to make a diagnosis, then I think that's too much, because more is not always better. And there's unnecessary morbidity for the patients with more extensive surgery, with subsequent complications, with lymphedema and so many other things. So I think at most 2 or 3 lymph nodes, if they're definitely enlarged, is sufficient. And beyond that, I think it's not really necessary. The other thing from a pathologist perspective is that if a lymphoma is suspected, if these nodes are enlarged, the process can be quite focal sometimes. It doesn't have to be diffuse. So our practice is to naturally, if there are a lot of nodes, not to submit them entirely in the initial go-around. We'll take representative sections. If you find a lymphoma there, then you probably don't have to sample further. But if what you're seeing is reactive, and there are a lot of reactive causes for significantly enlarged lymph nodes, then at least my personal practice, and I think most people working here and in other places as well, is that you should attempt within reason to submit the entire node, or if it's very, very large, to at least extensively sample all the nodes submitted so that you don't miss a focal pathology, because naturally the patient has undergone this procedure for a diagnostic purpose. And if you take 1 or 2 sections and you say that this is reactive, and then there's a pathology sitting in some other site, then I think this is the responsibility of the pathologist to make sure that things are adequately sampled. Just a word about cases that you can't make a diagnosis. Sometimes we sign things out, I think hopefully less and less frequently now, as an atypical lymphoid infiltrate. Some people could describe this as a biologically indeterminate lesion with some worrisome clinical features, but again, the diagnosis cannot be made. So the currently available criteria and interpretation, again, these are all, they vary depending on where you are and who's interpreting it. Important adjuncts would include, again, history, a good quality section and fixation and morphology, and how extensive is the immunohistochemical panel that you have available to you, what adjunctive molecular testing is available, and then naturally, everyone has limitations. I mean, there is a case that you cannot diagnose, but there are people out there who have more expertise, who have seen those cases, who just have a better eye than you. So I think that's the time to show those cases around, to seek an expert opinion, sometimes even sending them off to some renowned overseas expert as well. And so you will naturally, you'll try your best, and then you'll give it the best diagnosis you can. Sometimes we suggest a repeat biopsy in such cases, and sometimes they are truly reactive conditions that will regress themselves. Other times they are lymphomas, except we can't diagnose them on what's available to us. So we have to follow the WHO criteria, which we're just going to get into, and they go into the rationale for what is required to make a certain diagnosis. Naturally, communication with the submitting clinician or the treating oncologist or whoever it is, I think is very important in such cases. And things are not black and white. It always seems that whoever else is doing the interpretation, so for a lot of studies, it's histopathology is the gold standard. So those people doing histopathology know that it's a very gray area. It's not always black and white. Same way, when thinking about many molecular tests, we get the idea that it's some machine that is just giving out an answer. That may be true of some cases, but a lot of molecular testing, FISH, etc., also requires interpretation. So whatever you're doing, you realize that things are really rarely black and white. Generally, there is gray in it. And the important thing is that where you're unsure or where you think something else needs to be done, that should be communicated. And you should not give a diagnosis that cannot be supported. So again, classification. So this is a human impulse to classify things. I think going back to the sort of morphologic classifications of different species, lineage, etc. So this has been something that has been happening in all areas of medicine and science for centuries now. And what it does is it it sort of summarizes and encapsulates and orders whatever is known at a certain time. So it puts things into categories. And in lymphoma, this has been also going on now for close to a century. So we can see that in the 1950s and 60s, based on what was available then, which was basically hematoxylin and eosin stains, we had a classification of lymphomas, which were divided into nodular and diffuse. And then based on the mixture of cell types, whether they were small or large or mixed, whether they look like histiocytes. So we had a variety of entities. And subsequently, the working formulation actually was used for a very long time. And in places where immunostains are not available, I suppose it's still being used, since the later classifications all incorporated immunophenotype. So if you leave out immunophenotype, then basically you're left with the size of the cells, the chromatin, the mixture, the pattern, whether it's diffuse, whether it's follicular. And I think many of these entities are still applicable to some degree, but the gold standard of diagnosis has changed since then. So in the 1990s, it was felt that there was a lack of uniform terminology, especially between people in the US and in Europe, two traditional areas where I think a lot of this work was being done. So there was a lack of consensus, and certainly I think pathologists still lack credibility. And naturally, if the treating oncologists don't have much confidence in what the pathologist is saying or whether it means something, then that's sort of not a good thing. And then as more and more immunophenotypic and immunologic and genetic things were coming up, so there needed to be some order in all of this confusion. And this order was called the Revised European American Lymphoma Classification, or the REAL classification, which subsequently transformed into the first WHO classification in the early years of this millennium. So the REAL classification, as it was known, was new in the sense that it was a consensus with lots of experts. They had good input from the clinicians who were seeing the patients, treating them, who knew how these diseases were behaving. And it was, again, multifactorial, as we've already mentioned, with morphology, clinical, molecular, how things behave. And the efforts were that the criteria should be clear enough that these are reproducible. It's not like if I diagnose a lymphoma, naturally there's still a lot of gray there, but in the bulk of cases, I think many of these diagnoses are reproducible. Anyone else doing it comes to the same conclusion. There are probably 5 to 10% problematic cases where there's more judgment. Again, they have to be clinically relevant. And then the same terminology has to be used throughout the world. People should not be using one terminology in one place and another in another. So over my career as a pathologist, this WHO, we are now into the 5th rendition of this classification, and entities have come. Entities have become provisional. Some of them have become new entities. Some other entities have been merged into other things. So clinical context is important. Naturally, morphology is still the bedrock. Immunophenotype is a requirement more and more. Molecular genetics is making things clear. And then incorporating cytogenetics, next generation sequencing, other prognostic things. These are all things that are essential to making this classification what it is. And so again, for this one, like for the previous editions, it's been basically integrating pathologists in input, oncologists, research scientists, and then genetics, epidemiology, all of this. And then they've also defined what is essential versus desired. So some things are essential. Morphology is essential. Immunophenotype is essential. In some cases, genetics may be essential to make certain entities. So it's certain diagnoses without genetics cannot be made. But if you make a diagnosis on morphology alone, they also tell you what to diagnose and what to recommend for further testing. You can say that this is what is on morphology and immunostains. And then you can say in a note that these molecular tests are recommended for further workup. And if they're not available, or you can at least make that clear that these should also be done. So again, this is this 2022 hematolymphoid neoplasms. Again, it's essential and desirable. We've already gone over that. So we'll just briefly touch in some of the changes that have been made and some of the new entities that have come up. And some of it is actually whenever you do something by committee, you have lots of people, you have to, I suppose, make them happy to some degree. So some of these entities, it's just a minor tweaking in the name. I think it's like new wine in old bottles or something. So here, for one, they've now started with these mimics of lymphomas. So these entities that are things like reactive B-cell proliferations, florid reactive hyperplasia, progressive transformation of germinal centers, SLE-associated lymphadenopathy, infectious mononucleosis, which is one of the big mimics of overdiagnosing lymphoma. Then this entity of IgG4-related disease, which is obviously it's much more commonly seen in other parts of the body, but it can result in lymphadenopathy with lots of plasma cells with increased IgG4 expression. So that has been incorporated as a non-neoplastic type of cause of lymphadenopathy. Castleman disease obviously is not new. It's been divided into the unicentric form and then multicentric, one of which is associated with human herpes virus 8 and the other is idiopathic. But these are important things because they can give you very large nodes. Sometimes, in fact, some of the biggest nodes I've ever seen are in Castleman disease or in progressive transformation of germinal centers, where these lymph nodes sometimes can be 4 or 5 centimeters in size, but you don't find a lymphoma in them. So this, I mean, is just showing you some of the entities. Actually, this is not everything. So it's 2 pages of just B-cell neoplasms. So some of these are actually these pre-neoplastic. So again, these are, I suppose, of more interest to hematologists, the family of monoclonal B-cell lymphocytosis, where you have circulating lymphocytes in the blood, and on immunophenotype, generally by flow cytometry, the phenotype is such that this is clonal, and you end up with different types. It can be either a CLL type phenotype, but the count is so low, and you don't have any other features that this is a pre-lymphoma. This is a patient that needs to be watched, but they don't have an overt lymphoma yet, sort of like an MGUS or something. And then you can also have a non-CLL type. And there's low count and high count as well. And then in CLL, SLL, it's mainly unchanged. Again, they emphasize the importance of the mutational status. And as I mentioned previously, the P53 mutational status has been incorporated into the IPI as well. And again, so we were already using the Richter's transformation terminology for high-grade transformation as well. And this historical entity that I think we're all familiar with of B prolymphocytic leukemia or BPLL, it was defined not on immunophenotype, it was actually defined on morphology. Cells in a CLL that were somewhat larger, had more prominent nuclei, had more cytoplasm. So, but it's really, it's very subjective. And in view of that there wasn't a specific genetic signature or immunophenotype to distinguish it from CLL, I think they've trashed this category now. It's no longer recognized in this new classification. So in splenic B-cell lymphomas and leukemias already includes hairy cell, splenic diffuse red pulp, small B-cell lymphoma, splenic marginal zone lymphoma. The new entity that they've come up with is splenic B-cell lymphoma leukemia with prominent nuclei. And somehow all the new entities appear to have longer and longer names. This is something that is happening. And what this replaces is this entity of hairy cell leukemia variant. So there were cases that looked like hairy cell, but they did not have the same immunophenotype. So these are cells that have prominent nuclei, but they are negative for conventional hairy cell markers like CD25, annexin, A1, TRAP. So, and this is clinically relevant because this behaves in a more aggressive fashion than conventional hairy cell and may be resistant to the cladribine therapy as well. So in lymphoplasmacytic lymphoma, they've basically divided it now into two subtypes. One is associated with IgM levels, which is your traditional Waldenstrom macroglobulinemia type, which is more common. But they now also recognize that some of these patients will have a lymphoplasmacytic lymphoma that do not have elevated IgM levels, and they don't present clinically like a Waldenstrom with hyperviscosity and stuff. And again, the MYD88 mutation is already well known, and this is a driver mutation in this case. So in marginal zone lymphoma, what they've come up with is a primary cutaneous marginal zone lymphoma. And they've also come up with something, a pediatric nodal marginal zone lymphoma. Again, previously in peds, at least, we were comfortable that we didn't have to worry about marginal, but now we're going to have to think about marginal even in peds. And the mutational profiles of extranodal and nodal marginal zone lymphoma do differ. So they are biologically, they're different diseases as well. And also there may be different genetic signatures among extranodal marginal zone lymphomas arising in different anatomical sites as well. Follicular lymphoma, actually, they have made significant changes here. So the previous was a low grade, and then basically grade 1 and 2 were put into low grade, and then grade 3A and 3B were divided. So now they've actually put grade 1, grade 2, and grade 3A all together and put them in this entity of classic follicular lymphoma, where you have centrocytes and centroblasts, you have a nodular pattern, and it harbors the 1418 translocation with this fusion gene as well. And what they're saying is based on the clinical feedback and everything, and also the fact that this grading was quite subjective. I mean, on morphology, again, for anyone who's looked under a microscope trying to find which cells were centroblasts and which were centrocytes, it's quite subjective. Frequently, a Ki67 stain was used as a surrogate to guide that. That also has subjectivity. But if it doesn't really make any difference, so what they're saying is that all of these are put together as classic follicular. So you don't have to grade it. And then previously, the grade 3B follicular lymphoma, which was considered analogous to diffuse large B-cell lymphoma anyway, that is recognized as follicular large B-cell lymphoma. So that is what is previously 3B. And then they also define these things as follicular lymphoma with uncommon features. So if you have a blastoid morphology, or if you have a diffuse pattern, and especially with STAT6 expression, these are uncommon features, and these behave in a more aggressive fashion. In large B-cell lymphomas, again, new entities and things. So you have your diffuse large B-cell lymphoma, NOS, with germinal center and post-germinal center subtypes. Then the previous entity, the name has been evolving of this high-grade B-cell lymphoma with MYC and BCL2, the double hit or triple hit type lymphoma. So this is now put under this entity of high-grade diffuse large B-cell lymphoma. So again, if you don't have genetic testing available, a lot of these will have a high Ki index. You will have expression of BCL2, MYC, sometimes, frequently CD10 as well. And the practice, I think, is to describe these as diffuse large B-cell lymphoma germinal center type with a high proliferation index or high-grade features, and then recommend getting this genetic testing done. The other new entity is high-grade B-cell lymphoma with 11q aberration. So this is basically, morphologically looks like Burkitts lymphoma, but it's negative for MYC. And on immunophenotype, it's CD10, BCL6 positive in addition to 20. It's negative for BCL2. And on immunostain, MYC is negative. Again, MYC immunostain in most cases actually does not imply that there is a genetic mutation. MYC immunostain is quite commonly positive. The actual cases with a mutation in the MYC gene are quite uncommon. So the new entity also includes large B-cell lymphoma of immune-privileged sites. So this includes the entities of primary large B-cell lymphoma of the CNS, of the vitreoretina of the testis. And these are sites where normal immune surveillance doesn't really apply as much, generally seen in older adults. And again, they are usually aggressive tumors with a poor prognosis. And frequently, they have an activated B-cell phenotype. They're negative for CD10. Normally, EBV is negative. And again, we can see that they have different mutations. So the other new entity is something that again requires the clinical input, fluid overload associated large B-cell lymphoma. So we already had primary effusion lymphoma that was more in the setting of immune suppression. So this is without an underlying immunodeficiency. And again, it's limited to body cavities. It may be associated with cardiac or renal failure. And unlike primary effusion lymphoma, which was characterized as being HHV-8 positive, this one is HHV-8 negative, although some cases can be positive for Epstein-Barr virus. This confusing entity of gray zone lymphoma that is between classic Hodgkins and DLBCL is basically now they've narrowed it down more to only the mediastinum. Previously, you were allowed, they said it was more common in the mediastinum, but you could diagnose it anywhere. But now they say that it cannot be diagnosed outside the mediastinum. And this replaces again this previous long diagnosis of unclassifiable with features intermediate between DLBCL. But they've sort of limited the scope of this diagnosis. So if you're outside the mediastinum, then this diagnosis should not be made. In Burkitts lymphoma, they have something that was already, we were aware of it, that a lot of Burkitts is EBV positive and in endemic cases. So, but now they make a subtype. They divide it into EBV positive and EBV negative. So EBER testing, and again, we are doing EBER testing here by in situ hybridization. So I think that's the most sensitive way of doing it. Other labs are also doing it. So basically that's part of the pathogenesis. And it's shown that genetically it's different. EBV positive Burkitt shows higher levels of mutation. I'm not sure if there are any differences in therapy right now, but this is the current recommendation to stratify Burkitt's into two groups based on the EBV status. Then again, this is an example of synthesis of histologic diagnosis, other testing, and then the clinical setting, where lymphoma is associated with immune deficiency or dysregulation. So what they require is you have a histologic diagnosis, then you know about the status for EBV or HHV-8, and then what's the setting? Is this patient post-transplant? Is it HIV positive? Does the patient have an autoimmune disease and receiving therapy for that? Is it just immune senescence because of older age or something? So an example here that has been given is an elderly patient with DLBCL, which is EBV positive. So the integrated diagnosis would be diffuse large B-cell lymphoma, EBV positive related to immune senescence. In Hodgkins, classic Hodgkins, there's no change. And nodular lymphocyte predominant Hodgkin is still under the category of Hodgkins. But to make things more clear, I mean, nodular lymphocyte predominant B-cell lymphoma instead of Hodgkins, because it naturally, it's different from the rest. And it has B-cell markers. So that's why, just to remove any further confusion that someone will read the diagnosis of nodular lymphocyte predominant and could consider it nodular sclerosis classic Hodgkins, they've removed that now by calling this nodular lymphocyte predominant. Otherwise, the diagnostic criteria, everything remain unchanged. In plasma cell neoplasms, they've added sort of another entity to sort of the monoclonal gammopathy. If there's renal impairment because of that, that's MGRS now. Cold agglutinin disease, obviously, we were aware of it previously as well. So in cases in which there's a monoclonal cold agglutinin, which is related to an underlying B-cell proliferation, then that's part of this. And then two new clinical syndromes associated with plasma cells have been included as well. In NK and T-cell proliferations, they have, again, started with some of these lymphoma mimic entities. So indolent T lymphoblastic proliferation is actually cells that they can have immature phenotype, but it's not a lymphoblastic. Then Kikuchi-Fujimoto disease or just Kikuchi disease is actually not uncommon in Pakistan at all. I think in younger females and males, 20s and 30s with cervical lymphadenopathy, we probably get, I would say, half a dozen cases every week, maybe more. So it's quite common, and since it's something self-limited, I think it's important to distinguish this from other causes of lymphadenopathy. Then autoimmune lymphoproliferative syndrome is something that is a genetic disorder in which there's a germline mutation involving this FAS ligand. And what it results in is adenopathy, can be significant, waxing and waning. And the way it's diagnosed is by having an increased number of CD4 and CD8 double negative T cells circulating in the blood. The easiest way to actually diagnose it is on flow cytometry of peripheral blood, where there's a certain threshold for the number of double negative T cells, and you exceed that. But since these cells are also present in lymph nodes and other sites as well, so this is something that may mimic lymphoma. And personally, I have actually diagnosed this as lymphoma, and later on it was found out that it's ALP. So it is one of those known pitfalls. And one should be aware of this entity if you have an interfollicular proliferation of T cells and both CD4 and 8 are negative, and the other pan-T cell antigens are all intact, then this is likely ALPS. But the diagnosis should require either genetic testing or at least flow cytometry on a peripheral blood sample. We're getting to the end now. So in NK T cell, various types of cutaneous disorders were bunched together now, but now they're separated. And then we also have in the GI tract, there's again a change in terminology. And then they've also introduced an indolent NK cell lymphoproliferative disorder of the GI tract, which again is been recognized because of a particular genetic mutation, and it usually behaves in an indolent or benign fashion. In ALCL, the three types are ALK positive, ALK negative, and breast implant associated. And some new genetic tests are associated with both outcomes. And then again, PD-L1 expression can be seen in some cases of breast implant associated ALCLs as well. And again, angioimmunoblastic T cell lymphoma, which is actually also not uncommon here. Again, I think probably we diagnose 2 to 3 cases a month, if not more. And it's generally seen in patients 50 and above with significant adenopathy, hepatosplenomegaly, constitutional symptoms. And it's an aggressive lymphoma. And it's also one of those lymphomas that has a lot of morphologic mimics. It can look like Hodgkins. It can look like other things as well. Sometimes it can just look like a reactive lymph node. So here the terminology is basically changing it to nodular T follicular helper cell angioimmunoblastic type. So again, the diagnostic criteria remain unchanged. It's just a change in terminology. And on this, I don't have enough pictures, so not a very good picture, but this is a lymph node which is effaced. On this higher power, we can appreciate that these are some prominent endothelial venules, and the polymorphous population of cells, again, doesn't project very well. So these are T cells. They are not very atypical morphologically. So you have to do multiple markers on these to identify. And generally, to make this diagnosis, they have to be CD4 positive. So this is CD4 is all positive in these cells. CD8 will only stain a few background reactive T cells. T follicular helper markers, which are CD10, BCL6, and PD-1 are generally, at least 2 of them are required to be positive. So this is an example of CD10 expression here, which is positive in these. So, and CD20 stains only scattered background B cells and some immunoblasts. And some of those immunoblasts can look very much like Reed-Sternberg cells. So this is one of those entities where this is something that can be misdiagnosed, and I think requires coordination between the clinical findings and histopathological evaluation and immunophenotype. So then this extranodal NK T cell lymphoma, previously it had the qualified nasal type, but since it occurs in other sites, that they've dropped that. The other thing is previously we did not have an entity of a nodal EBV positive T and NK cell lymphoma, but they've added that. And again, they say that it's usually advanced disease and has a bad prognosis, and it can mimic diffuse large B-cell lymphoma. And finally, they've just added some of these mesenchymal tumors have been added in the classification. These entities already existed, just they've been made part of this classification now as well. So again, I think with that, I'll end. So we can see how classifications, they evolve over time, they make things in organized, they define entities, they should be clinically relevant. And again, like we've seen in follicular lymphoma, whereby the grading did not have clinical relevance, or so that's why it was removed. Again, as more and more molecular targets are defined, you can have targeted therapies for them, and research goes on. And ending with this nice quote that everything should be made as simple as possible, but not simpler. So with that, I'll end. If there are any questions, I'm happy to take them. Thank you.